At this time, it is my pleasure to introduce you to Ashok Bhasin. Ashok, the stage is yours.
Welcome, everybody. Today is the second lecture in the series of International Thyroid Awareness Week. So welcome to the 14th International Thyroid Awareness Week. Each year, for 14 years now, we have provided education programs for the benefit of our global audience. Online webinars are the best way we can reach a global audience. Online today, we have people tuned in from Australia, in the Far East, Asia, Africa, Europe, and the Americas, Brazil, US, and Canada in the West. We thank Merck Serono, Horizon, Exelixis, IPSA, Immunovent for their support. Merck KGaA Germany has been supporting this International Thyroid Awareness Week for the past 14 years. We also want to thank Porter Novelli from Marco. You just heard he's based in Geneva and his partner based in London. They are hosting this webinar for us today. I am your host. My name is Ashok Bhasin. I'm based here in Canada. I'm the president of Thyroid Federation International. So before I go further, I would like to introduce you to our speaker today. Our speaker today is Dr. Kelsey A. Roelofs. Dr. Kelsey is an ophthalmic, plastic, and reconstructive surgery fellow. She's from University of California, Los Angeles, and she has done her honors in physiology and Doctor of Medicine from University of Alberta. She's a fellow Canadian, and ophthalmology residency from University of Alberta. She's also a fellow in ocular oncology and a part of American Society of Ophthalmic, Plastic, and Reconstructive Surgery. So as you see today, we have somebody special on the side of ocular oncology, which is related to thyroid eye disease that we have not had this opportunity before in terms of high specialization in this area. So you would hear from Dr. Kelsey. What I would suggest is that, since Dr. Kelsey is, of course, way in Pacific in California, where it is 5 o'clock in the morning right now, not possible for her to be online. But if there are questions after her lecture, please write down in your chat, and we will answer those questions directly from her to you via your emails. So before I go further, here is Dr. Kelsey, and over to you, Dr. Kelsey.
Hi everyone, my name is Kelsey Roelofs. I'm one of the Oculoplastic Surgery Fellows at UCLA, and today I have the privilege of talking to you about thyroid eye disease. My goal in this presentation will be to go over an approach to diagnosis and then also cover some options for management. So this is sort of the general outline that we'll go through. We'll briefly discuss pathophysiology and epidemiology, and then really get into the meat of the discussion with clinical features and management. So in terms of thyroid eye disease, as many of you may be aware, in the medical literature there are several different terms that are used to refer to this condition. But for the purpose of consistency for this talk, I'll refer to the condition as thyroid eye disease. Thyroid eye disease is an autoimmune condition, and it's often, but not always, associated with Graves' disease. Characteristic findings are really what allow for the clinical diagnosis. So there is not one specific laboratory test or imaging feature that allows us to diagnose thyroid eye disease. It's really a constellation of many different findings. I think one really important concept that I'd like to try to drive home during this lecture is the classification of thyroid eye disease based on disease stage and disease grade, and we'll get into that more later. And then finally, we'll discuss treatments, and the disease stage and grade are really important because it helps guide our treatment making decisions. So in terms of the epidemiology, about 90% of patients with thyroid eye disease will have Graves' disease. About 6% will be euthyroid, and the remainder will will have Hashimoto's or primary hypothyroidism. Now, of those 90% of patients with Graves' disease, you might wonder, of patients with Graves' disease, how many are likely to develop thyroid eye disease? And that number sits between 20 and 50%, depending on what literature you read. So who are these 20 to 50% that develop thyroid eye disease? Well, thyroid eye disease is 6 times more common in females, although the caveat is that the disease is often more severe in men. Thyroid eye disease typically does not have an ethnic predisposition, and the average age of onset is between 30 and 50 years. Now, I will say the majority of patients who develop thyroid eye disease do so within about a year of developing systemic thyroid dysfunction. So if you've developed Graves' disease 20 years ago and have had no eye symptoms, you're very unlikely to develop thyroid eye disease at that time. In terms of the pathophysiology, production of glycosaminoglycans, including hyaluronin, and volume expansion of fat and muscle, both result as occur due to this antibody stimulation. Recent research has shown that the TSH receptor and the IGF-1 receptor co-localize on orbital fibroblasts, and this is thought to play an important role in the pathophysiology of thyroid eye disease. So as I mentioned, it's really a constellation of signs and symptoms that lead us to the diagnosis of thyroid eye disease. So we're going to go through a number of different features here. We'll begin with the eyelids, and one of the most characteristic features of thyroid eye disease is upper eyelid retraction and lateral flare. You can see in the normal patient shown on the top, the red line denotes the MRD1, or the margin to reflex distance 1, and this measures from the center of the pupil to the upper eyelid margin. In the patient in the bottom photo who has thyroid eye disease, you can appreciate that this distance is significantly greater, and you can also see that there is some sclera, which is visible above the iris. We call this superior scleral show. Now, in addition to just the height of the eyelid, the contour of the eyelid also changes in thyroid eye disease. Our normal patient exhibits that almond shape to the upper eyelid contour, whereas the patient who has thyroid eye disease has a much more rounded curvature. You can appreciate that the lateral upper eyelid is retracted preferentially. Now, just to show you that this is not, differences between two individuals, this is actually the same patient, but 15 years prior to the development of thyroid eye disease. And you can see that at that point in time, she had no upper eyelid retraction, and her upper eyelid contour was similar to the normal patient shown previously. Mild cases of upper eyelid retraction often spontaneously resolve, and so this is a patient who had more mild lid retraction and lateral flare, and at 15 years follow-up, you can appreciate that there has been a significant improvement without the need for any surgical intervention. So in mild cases, as long as you can symptomatically get the patient through the acute phase, oftentimes they do very well. Now, lower eyelid retraction can also occur, and in this photo, you'll appreciate that the globe is more proptotic. It's coming further forward compared to the midface. And this leads to what we call a negative vector. You can see that's denoted by the red line there. And so you can imagine that it's difficult for the lower eyelid to climb up a hill. And so oftentimes in patients who are particularly proptotic, we can see this inferior scleral show and lower eyelid retraction. Now, you can also develop eyelid edema and erythema, and this is particularly common in patients who are in the active stage of disease, and you'll appreciate that there is often asymmetry in thyroid eye disease. Now, in terms of orbital signs, we already briefly touched on proptosis when we discussed lower eyelid retraction, but this is a better photo showing that the globes protrude further from the eye and further from the midface than they do in the normal situation. Restricted extraocular motility and/or strabismus is also a characteristic feature in thyroid eye disease, and this patient demonstrates some sort of specific patterns for this. So you can see in the top photo, looking in primary gaze, that she has a strabismus. The right eye is pointed down compared to the left eye, which is straight ahead. Now, in the photos that are demonstrating different positions of gaze, you'll appreciate that the right eye really cannot look up very well. And so not only is that indicative of this hypotropia, is what we call when the eye is looking down in primary gaze, it's likely due to large enlargement and restriction of the inferior rectus on the right side. And that is the most characteristic muscle to become enlarged in thyroid eye disease. Now this can also impart a secondary upper eyelid retraction because the muscle that moves the eyeball up and the muscle that lifts the eyelid are sort of linked together. As you can imagine, it's very difficult to look up without having your eyelid also go up. And so this upper eyelid is partially retracted because the inferior rectus is so tight, and the superior rectus is working very hard to try and pull that eye as close to center as it can be. So secondary upper eyelid retraction can also be seen in thyroid eye disease. Moving on to some ocular surface signs, you can appreciate a significant amount of chemosis in this patient. This type of chemosis would often be present during active, moderate, or severe disease. And again, note the asymmetry. So although most cases of thyroid eye disease are bilateral, highly asymmetric disease is not that unusual. Injection of the conjunctiva can also be seen. You can appreciate some redness there. And again, this is an inflammatory feature more commonly seen in the active stage of disease. And exposure keratopathy can occur. Here you'll appreciate that when the patient is trying to close her eyes, there is still a gap between the upper and the lower eyelids, denoted by the white arrow there. And so this can lead to significant dryness. On the bottom photo here, we have a slit lamp image demonstrating staining of the cornea with fluorescein. And all of this punctate, sort of speckled staining in this region is showing some breakdown of the ocular surface due to the exposure and the dryness. Superior limbic keratoconjunctivitis can be seen on its own. It is an independent entity, but it's often seen in association with thyroid eye disease. And in this condition, you'll have injection located in the superior conjunctiva, and that conjunctiva will be a bit thick and boggy, and it can also stain with lissamine green, which is a more sensitive stain for this condition. And finally, moving on to some of the periorbital changes, you can appreciate that there is expansion of the eyebrow fat and the dermis, and this also fortunately tends to improve with time. I say fortunately because this is a very difficult problem to address surgically. That thickening is sort of an integrated, ill-defined, diffuse process, and it's very challenging to achieve a natural surgical outcome if you try to go in and debulk it. So the tincture of time is perhaps the best method for dealing with periorbitopathy. So now I'd like to go on to some radiologic signs. Of course, on imaging, enlargement of the extraocular muscles is one of the most commonly seen features in thyroid eye disease. Here we can appreciate an MRI showing normal-sized extraocular muscles, and this patient has TED with significant enlargement, in this case of all of the extraocular muscles, but as I mentioned, they tend to enlarge preferentially inferior rectus, medial rectus, superior rectus, and then lateral rectus, sort of in a spiral. Lacrimal gland enlargement has also been demonstrated in thyroid eye disease, and with the white arrow here, you'll appreciate a slight increase in size in the lacrimal gland. Bowing of the medial orbital wall can also be seen. You can appreciate here that in the patient with TED, the bone is bowed medially slightly, and this is thought to be due to chronic pressure in the orbit causing bony remodeling, so it tends to be associated with more chronic or long-standing disease. And finally, this is a feature that we're just writing a paper about now, but periphlebitis of the superior ophthalmic vein also appears to be an imaging feature seen in about 5% of patients with thyroid eye disease. So moving on to the symptoms. Ocular surface symptoms can include tearing, foreign body sensation, light sensitivity, and dryness. And then when we put it all together, you can see that this is what I mean when I say we take a constellation of signs and symptoms. There's a number of things that really contribute to coming up with the clinical diagnosis of thyroid eye disease. So let's move into discussing a little bit about disease stage. So in thyroid eye disease, generally we think of patients as either being active or inactive. And then in terms of defining the severity of disease, we typically group patients into mild, moderate, and severe. Now you can have mild active disease or mild inactive disease, and the same goes for moderate and severe. So it's really between all of these things you can describe quite well where the patient is sitting. In terms of disease activity, we tend to think that there is generally an active phase that lasts maybe for about a year or 18 months, and after this you reach the more stable inactive phase. During the active disease phase, you can appreciate here, this patient has a significant amount of chemosis and injection, and this is the same patient after treatment and after he's reached the inactive phase of thyroid eye disease. He does still have some features of TED, for example, the upper eyelid retraction and the lateral flare, but the injection and the chemosis are significantly improved. Now, one thing I tell all of my patients is that if you're not a smoker, that's excellent. And if you are a smoker, the best thing you could do for yourself is to stop smoking, because smoking has been shown to both increase the severity of the active disease and also prolong the duration of activity. So really, this is, I think, the most important modifiable risk factor in thyroid eye disease. It's something that needs to be discussed with everyone who comes into your clinic. One extra caveat I'd like to make about the severe category of disease is patients who have dysthyroid optic neuropathy. Dysthyroid optic neuropathy can either be from mechanical forces, so compression of the optic nerve as it's leaving the orbit, or from inflammatory characteristics, also occurring generally at the apex. And sometimes it's difficult to differentiate between the two. But in terms of monitoring for dysthyroid optic neuropathy, often we're checking color vision, we're checking visual fields, and we're looking at the optic disc to see if there's any swelling or other signs that perhaps the nerve is not functioning normally. This is important because this needs to be treated in a more expedited fashion, and there are a few medical treatments and a few surgical treatments that we'll discuss later in the presentation. So when we bring it all back together, we generally think that supportive and medical treatments are most appropriate in the active phase of disease. And this is because surgery during this phase of disease can occasionally make things worse. In the inactive phase of disease is typically where our surgical management comes into play the most. But that being said, there are of course exceptions to any rule. So in cases such as patients who have dysthyroid optic neuropathy, in some instances surgery is necessary in order to decompress the apex. And similarly, with some of the new evidence that's emerging about targeted treatments, including Tepratumamab, medical treatment is sometimes the best option in inactive disease. So there is some nuance that goes into decision-making when it comes to treatment and disease stage. Now, our goals of treatment in the active phase of disease is really to improve symptomatology, to get the patient through that 12 to 18 months and then sort of see what sort of residual changes we're left with. And in inactive phase, we're going to work towards rehabilitation. In terms of the supportive treatments for thyroid eye disease, of course, lubrication can be used by anyone. You know, it doesn't have a lot of side effects unless you're using it a lot, and you can get some toxicity from the preservative, but in that case, you can use preservative-free preparations. Selenium actually has some evidence in the supportive management for mild thyroid eye disease during the active phase. And the dosage that was studied in this New England Journal of Medicine paper was 100 micrograms twice daily. In terms of medical treatments, there are a lot of options. So for the purposes of this talk, I'm very briefly going to go over them just so that you have a flavor of what's out there. Corticosteroids have traditionally been our mainstay for treatment of thyroid eye disease. They've been around for a long time. Intravenous corticosteroids are generally better tolerated than oral, although the side effects can be significant with either route, and it's important to keep the total cumulative dose below 8 grams. Otherwise, there can be a significant risk of very serious side effects, including liver failure and fulminant liver failure and cardiovascular events. Rituximab is a chimeric human and mouse monoclonal antibody against CD20. There have been 2 prospective randomized studies looking at this medication in the treatment of thyroid eye disease, but they've had contradictory results. So in my practice, I'm not entirely sure where rituximab fits. There is perhaps some evidence that it could be useful in treating patients who have corticosteroid-resistant severe disease, but I think more remains to be known about the role of rituximab in thyroid eye disease. Tocilizumab has the benefit of coming in a pre-filled syringe that can be administered via subcutaneous injection, so patients can do this at home, which is helpful from a logistical standpoint. It's possible that it may have a role, again, in steroid-resistant severe cases, but additional prospective studies are really required for us to know exactly where this fits in the treatment algorithm. Now, Tepratumomab, I'm sure many of you have heard about this medication. It's really created a wave of sort of new treatment paradigms when it comes to thyroid eye disease, and certainly many patients come in asking about this medication. It's a humanized monoclonal antibody against the IGF-1 receptor. And this is really based off of basic science that showed co-localization of the IGF-1 receptor and the TSH receptor in orbital fibroblasts in TED. So there's been two large prospective randomized blinded studies on Tepratumamab, both published in the New England Journal of Medicine. This was the first of the two studies. Their primary outcome was to see whether patients had a 2 millimeter or more reduction in proptosis. And so they found that 69% of those on Tepratumamab achieved this primary outcome versus 20% of patients receiving placebo. The average reduction in Tepratumamab treated group was about 2.5 millimeters. Now, CAS is an inflammatory scale, so this kind of encompasses some of the signs that we talked about earlier, the injection and the chemosis. It also includes features like retrobulbar ache and pain with extraocular motility. And so they found that Tepratumamab was also quite effective compared to placebo at decreasing this. They looked at a quality of life score for vision and found also a significant difference there, and a quality of life score for appearance. Finally, they also found that Tepratumamab tended to reduce the diplopia more than placebo, although the scoring scale that was used in this study is sort of suboptimal, as it doesn't have very many levels. It's the Gorman scoring scale, and it says improved, the same, or worse, basically. Now, the second study showed remarkably similar results. You'll see here patients got about the same amount of decrease in proptosis. Again, CAS was reduced. There was an overall response rate of 78% to Tepratumamab, improved scores on the quality of life scales, and improvement in double vision, again using that same Gorman scale. One thing I would say from my own clinical experience is that Tepratumamab is certainly not without its side effects. There can be hearing loss, dizziness, nausea, hyperglycemia, and so that needs to be monitored. And then non-specific side effects, including diarrhea and alopecia, have also been noted. So this was a really great paper published quite recently, just going over the update in terms of medical treatments of thyroid eye disease in 2020, because as I mentioned earlier, Tepratumamab changed the approach for some people. And one thing I would like to point out to you is the tremendous difference in cost. So injection of methylprednisolone steroids, which are sort of the traditional treatment for patients who require intervention and have active disease, is about $500. And this compares to Tepratumamab, which costs about $350,000 for a cycle of 8 infusions. The other thing I'd like to go over quickly is some of the local therapies that we have for thyroid eye disease. So we can locally inject steroids. This is particularly helpful for patients who have significant orbital pain. And the main benefit is that you don't get the same sort of systemic side effects from steroids as you would from IV methylprednisolone. Now, of course, there are some risks anytime we inject anything with a particle into the face or into the eye socket. There's always a small chance of intravascular injection, but in general, this is quite an efficacious way to improve patient symptomatology. Hyaluronic acid filler is also a very helpful tool to have in your toolbox. And so you can see this patient had quite significant upper eyelid retraction on the right. Some hyaluronic acid filler was placed in the levator plane, which is the muscle that lifts the upper eyelid open, and you can see that immediately there's an improvement in the upper eyelid position. Now, this is a temporary solution. The filler dissolves over time, but it can be a really nice, very elegant way to get a patient through the active phase of disease while you're waiting to do surgery in the future. Radiotherapy can also be used in thyroid eye disease. The ideal candidates are really those who are in the early active phase of the disease and those who have moderate to severe disease, especially patients who have extraocular motility limitation. It can be helpful if there's progressive strabismus as well. And it's generally used in combination with systemic corticosteroids. So let's briefly go over some of the surgical options for management of thyroid eye disease. When we come to the orbit, we can do decompression of several walls, and we can also remove fat. So if someone only needs, say, 1 millimeter reduction in proptosis, a fat-only decompression may get them there. But that's really not the majority of our patients. Most patients do need some bone removed, and so there are several surfaces that are available for this. This area highlighted in green highlights the greater wing of the sphenoid bone, and there's generally a large section of marrow space there that can be removed using a high-speed drill to allow the eye to move posteriorly back into the orbit. You can see on the CT scan this area of bone highlighted in green. This is what would traditionally be removed during a deep lateral decompression. Now, a medial decompression can also be performed, in which we open up the medial wall into the sinuses, and the area of bone removed in these instances is highlighted in blue. And for patients who have more significant proptosis and need a greater reduction, we can remove all three bony walls to allow maximal expansion in orbital volume. In terms of strabismus, this is typically performed following orbital surgery because orbital surgery itself does carry a risk of strabismus. We usually quote patients about 5% risk of strabismus for the lateral wall and about 15% for the medial wall. So some oculoplastic surgeons will perform strabismus surgery. Other times the pediatric ophthalmology team will take over for this part. And the goal is really to shift that field of single vision into the most usable space. So if a patient has single vision in lateral gaze, to shift that into primary gaze. Now, the eyelids are typically dealt with last. As I mentioned, mild cases of upper eyelid retraction can occasionally resolve on their own, but more significant upper eyelid retraction often requires surgery. And so you can see this patient has had upper eyelid retraction surgery, and lower eyelid retraction surgery can also be performed in some instances. And so in thyroid eye disease, occasionally the retractor plane will become contracted, analogous to the upper eyelid retraction. And so we can separate that and occasionally place some material in there, either a dermis graft or another substance that can just provide basically some space to elongate the posterior lamella. So this is a patient before and after decompression, strabismus surgery, upper and lower eyelid retraction surgery. So really, in summary, diagnosis of thyroid eye disease is based on a constellation of signs and symptoms, not one specific thing. Thyroid eye disease typically occurs within 18 months of being diagnosed with the systemic disease, and management is typically based on disease grade and stage. In active disease, the goal is really to improve symptomatology and patient comfort, whereas in inactive disease, we're aiming to rehabilitate the patient. Now, mild, moderate, and severe disease grades can help guide the management in thyroid eye disease. And a combination of all of these factors must be taken into account to come up with the most customized treatment solution in thyroid eye disease. For example, someone who has active disease that's mild might be best suited with supportive treatment, whereas those with moderate disease might require medical treatment such as Tepratumamab, and patients with active severe disease sometimes require medical treatment, sometimes surgical treatment, particularly if they're in the inactive phase. So thank you so much for your time and attention. It's been a privilege to present to you, and I'd be happy to take any questions.
Hello, everybody. Well, thank you so much, Dr. Kelsey. Much appreciated taking the time to put up such a good TED presentation, that is thyroid eye disease. And thank you for putting it in such a short time with a quick turnaround time, and very well done. I'm sure everybody here today will appreciate the presentation that she has put together. And I wanted to thank you, Dr. Kelsey, on behalf of Thyroid Federation International Board and its members across the globe. Like you can see, people are here from Argentina, Brazil, also in the Pacific area. So thank you very much for all of you to join us here today. I'm very thankful to our TFI board members, Beata from France, Nancy from USA, Linda from Italy and Spain, Peter from Sweden, Dr. Feridul from Bangladesh, and Bohana from Serbia for their support and efforts in putting all this thing together. And again, without having the sponsors support us, it's not possible to do anything. So we would like to thank Merck Serono, Horizon, Exelixis, IPSA, Immunovant for their support. And Merck KGaA Germany has been supporting the International Thyroid Awareness Week for the past 14 years. And I also wanted to thank Porto Novelli in UK and Visualizing Ideas in Geneva, Marco, who's the host today from there, for hosting this program. We will get Dr. Kelsey send you the answers to your questions, which are all noted, and we will directly get the answers from there. Dr. Kelsey is at 5 o'clock morning there, but pretty early in the Pacific area. So thank you all, and this concludes our lecture series for the patient, from the patient perspective, which you saw on the World Thyroid Day. And incidentally, World Thyroid Day was created by Thyroid Federation International way back more than 20 years ago. And then you got the endocrinologist perspective from Dr. Larry, Nancy, for patient perspective, and also the perspective of ocular oncologists and ophthalmology today. And hope you like it, and it will be available on our YouTube channel. We will send a link to you, and if you can subscribe to our YouTube channel, that will be really great, because then we can have a full TFI YouTube channel that you can have a lot of lecture series from the past also view. So that's all from now, and thanks again to everybody for joining us today. Much appreciated. And next we will be doing a lecture on cancer, thyroid cancer side. That will be in the Thyroid Cancer Month, which is supposed to be in September. You will hear from us on that. So once again, thanks to everybody for putting up these programs, and bye from